Just asking you briefly to give me a brief description of your center, who it serves, where it's located, etc.
Yeah, our healthcare center is a major primary care center in Puerto Rico. Out of 19 healthcare centers, 330 funded. We serve a population of 59,884 patients by the UDS number of 2010, and we serve mostly the center's southern population of Puerto Rico, facing the Caribbean Sea. We have one main site and 3 satellite centers in adjacent nearby towns. Also 2 mobile units, which are site centers as well. Those mobile units, one serves the 9 public housing centers, and the other one serves the migrant seasonal farm workers in the farms in the southern part of the island. We also serve 2 schools, and just today we got the news that we got granted for serving 4 additional schools in southern Puerto Rico through means of a new mobile unit that we will be acquiring. We comprise nearly 316 employees, most of them healthcare professionals. And our healthcare services, it's a comprehensive healthcare center. We go from prenatal, OB/GYN, pediatrics, family medicine, internal medicine, general medicine, urgency, emergency, one-day surgery center for general surgery, ENT, and orthopedics. Also, we are considering ophthalmology to be added to the surgery room. We also have a dentist in all our healthcare centers. We have, for instance, in our main healthcare center, we have 7 dentist chairs. In all the satellite centers, we have either 2 or 3 dentist chairs. Also, ancillary services comprise a pharmacy. It's a full-service pharmacy. It's run by robots, robotic technology. So the 200 most demanding medicines are dispatched by robot. Also, we have a laboratory. It's a comprehensive laboratory, so all laboratories are made right in the place. Then we have imaging, which is X-rays, mammogram, sonogram. We do echocardiograms as well, and we do also EKGs. So it's a very comprehensive healthcare center. Also, we have services, support services like social workers, nutrition. We have as well VISTA volunteers. They don't call them volunteers anymore. VISTA participants, which it's 10 outreachers out in the community, outreaching for patients to work, to come and be served. This VISTA also, of course, they are mostly in the public housing units. We also have senior companions program. We have 40 participants in the senior companions programs, which visit and supply minor services to those in the homes who are more ill, and they can be served by their own. So it's a pretty comprehensive healthcare center.
It sounds like it, and congratulations on your grant. Tell me a little bit about how you see the importance of these public housing primary care programs in communities, not only in Puerto Rico, but across the country.
Public housing communities are isolated communities. In fact, even though if they might coexist in the urban areas, they are de facto isolated communities. Those living in these communities are harder to serve because of the social stigma built on them, and because of the social stigma they build in response to the stigma built on them. So these communities are communities whose residents are probably either not receiving the adequate service or receiving no services at all. So these are, in fact, special communities. In Puerto Rico alone, there are around 52,000 units of public housing. So it's a huge community living in public houses. Those living in Puerto Rico, the government years ago either isolated them furthermore by building fences so they couldn't go out or come in except by a main entrance where they have guards, armed guards, controlling the entrance or the exit of those residents. So in Puerto Rico, they might be a little bit different than in the States, but still it's the very same problem.
Now, are there any success or impact stories that you can recount for us where you may have impacted either a community or individual family or individual person that you can relate to us?
Yes. Because of this stigma built in these communities, they have become fair ground for drug dealers to have their business run in there. So to be able to serve these people, which we found there are plenty of good people living in this public housing, just like you and me, anybody, you know, professionals as well, but they are stigmatized. And the drug dealers take advantage of that. So in order to be able to go there, which mostly people just don't want to go into the public housing, we develop what we call pseudo-collaborative agreements with the drug dealers and let them know we are in here not to harm you, we don't care about your business. Somebody else will take care of that. We don't tell them that, of course. But we're here to serve the people. And then we have no problem with the drug dealers. Otherwise, you know, we would not even be able to enter those many of those places. And in fact, when there are going to be problems in the community, they even warn us, you know, just don't come here today. There will be problems, but we just don't go there. And but we go visit these public houses on a scheduled basis. So I think this is really a success story. We don't know of any organization ever attempting doing something like that in the public housing in Puerto Rico.
That's amazing. What about in terms of feedback from the folks you serve? Has there been consistent feedback? Have you been able to get a sense of how they're feeling about the services you're providing?
Yes. In the beginning, when our mobile units, we serve our public houses through mobile units. We don't have stations in the public houses. It's a strategy because we could serve more public houses. In fact, we serve 9 altogether. In the beginning, it was hard to get people to come into the mobile units. These are subcultures. They just don't behave like the rest of the community. So we have to adapt ourselves to the community and do our business, if we may call it like that, you know, according to the community. So today the story is very different. We have one of the major public housings we serve. I think it's got 1,300 living spaces. It's a member of our board of directors, and she is a leader, and she acknowledges, and she is the one doing the outreach for us among the community. So right now there is a turnaround in the way these mobile units are going. Before, they were served by other practitioners, and they were not really receiving the services, the full standards of care. But because this is a federally qualified healthcare centers, our standards of care are very, very high, and they have begun to acknowledge that as the best place to receive service. And also, I have to mention that our personnel not just provide the primary care service, but they educate the community as well in why they should have a visit, at least one visit a year, to their primary care provider.
And you talked a little bit about your collaboration, so to speak, with the drug dealers. Are there any other partnerships or collaborations that sort of officially help you achieve your goals?
Yes, we have major agreements with all 4 hospitals in the area. So our patients' referral just goes straight through to the hospitals. And that's a major advantage as a primary care provider or organization. Many of these patients, besides receiving primary care, they need continuum care in some cases. So that helps a lot. Also, we work with the city government, and we have our mayors, you know, cooperating at all times with us. Every time they have a fair, we collaborate with them, especially if they are fairs in the public housing complexes. And when we need anything from them to work in the public housing complexes, they provide the help. We never use the police to help us. The police is not well seen in the public houses. They do a good job, but I mean, it's just a stigma. So they will not be of much help. So we do have that collaboration.
And what collaborations that are not happening now would you like to see happen that could help you achieve your goals?
We would like to have the state government be more aware of the work we do, acknowledge that work, see that we are a community-based organization. Our board of directors is comprised by people from the community, not pseudo people from the community. This is a farm worker, this is a public housing resident, this is an artisan, this is a metal works worker. We do have a doctor, we do have a lawyer to balance the board of directors. But the core, 70% of our board of directors is people from the community. So sometimes government overlook the importance of these people, what they have to say, what they have to think. And it is those people who can better say what their needs are. So state government really needs to give more importance to what the people from the communities of the public housing have to say.
Finally, what are some of the biggest barriers you found? You mentioned one now, the state government not sort of acknowledging the work you do and some of the folks involved, but what are some of the barriers that you found to achieving what you do?
Access to health care for people living in public houses is a major barrier. We overcame it by bringing mobile units. However, the public housing authorities should be more concerned about the work we do for their communities. Just today, I was in the roundtable meeting we had. I was suggesting that, for instance, high-ranking officers from HUD meet with the directors of these, any of these 55 public housing grantees across the nation, so we could give a feedback on how HUD could get more involved, because we are providing healthcare services to projects being served by HUD. So by HUD listening to the grassroots, they could probably set aside, probably not that many fundings as they might think we might need, but some extra funding that will further improve the quality of services we provide.